Hello, everybody, and welcome to the webinar this afternoon on how to talk about SUDEP. I'm Dr. Sandy Dewar and will moderate the session today. I have worked as an advanced practice nurse in epilepsy for many years and currently hold a faculty position in the Department of Neurology, School of Medicine at Virginia Commonwealth University in the USA. First of all, a very warm welcome to all our attendees around the world and for accommodating time differences wherever you are. A couple of housekeeping items. The audience will be muted during the presentation, but there will be time afterwards for discussion. Please use the Q&A function to send your questions and comments. Very important, membership information and an evaluation will post at the end of the webinar. We welcome new members and we would love to have your comments on the evaluation sheet, which will only take a couple of minutes, so please stay on long enough to complete it. Very special thanks to our speakers who have put together wonderful talks today, and especially the team who helped to put this webinar together. The focus today is how to talk about a very sensitive topic of sudden unexpected death in epilepsy. We will not be talking about the mechanisms of SUDEP, but rather will focus on different perspectives of when and how to prevent information about SUDEP and the risks of SUDEP. We will talk a little about how people cope when SUDEP happens, and we ask our audience to reflect on how to overcome conversational barriers in their own practice. And just as a reminder, the webinars within the nursing section of the ILAE afford a platform to promote our work as nurses, to share our ideas and to learn from each other. So I will keep the introductions of our speakers brief, but this also means that the introductions really do not do justice to the many accomplishments of our speakers today. And again, thank you to them for so generously agreeing to speak on such a sensitive topic. Edana Perry is our first speaker. She is the mother of a young woman named Kayla, who very sadly lost her life to SUDEP in 2017. Kayla was her youngest child. In addition to being an active mother and grandmother, she is a minister, poet, and author. 2 years after Kayla's death, Edana and her husband established the Kayla Ross Perry Memorial Foundation as a way to raise awareness about epilepsy and specifically SUDEP. Edana and her husband Bernard live in the United States, just outside Washington, D.C. Yasmin Hibbins will speak as a person with epilepsy. She currently lives in rural Victoria, Australia, with her husband and three children aged between 9 and 11 years. She had an unfortunate traumatic brain injury about 10 years ago, but was more recently diagnosed with epilepsy. And she will be telling us a little bit about what it was like to be told about SUDEP. Sammy Ashby is the CEO of a charity called SUDEP Action. During her 10 years with SUDEP Action, she worked on clinical training, research, and political campaigning for the prevention of epilepsy deaths. She has also helped develop a risk assessment tool, which is available freely for health professionals and people with epilepsy, the goal of which is to improve communication about how risk is understood and managed. Our last speaker is a clinician speaker today who will present a talk entitled Talk to Me, Patient Care Partner Perspectives on SUDEP Disclosure. Dr. Lucretia Long is an experienced epilepsy nurse practitioner who spends the bulk of her time in outpatient epilepsy care. She is involved in clinical research and has a wide range of interests, including the use and development of seizure action plans SUDEP, talking about SUDEP, and best approaches for patient and family education. She is a clinical associate professor of neurology in the College of Medicine at the Ohio State University Wexler Medical Center in the United States. So with that, we will move to our first speaker.
Good day. My name is Edana Perry, and I want to first thank Nancy and the International League Against Epilepsy for the opportunity to share our story. My husband Bernard and I were blessed with 3 children, Taylor, Christian, and Kayla. Our youngest, Kayla, was graced with epilepsy at the age of 11 in 2002. She was diagnosed with juvenile myoclonic epilepsy, in which her seizures started with tremors of her arms and legs and then transitioned in a grand mal seizure. Her seizures were triggered by lack of sleep. Now, as people of faith, we believed that she would be healed. In the meantime, though, we were committed to ensuring that Kayla would have as much of a normal life as possible. It was a challenge at times for Kayla to get the appropriate rest and have a social life. She enjoyed cooking, modeling, playing soccer, dance, youth choir, and she was an active member of a community gospel choir. Her medication Depakote was prescribed to minimize the seizures since getting 12 plus hours of sleep was not really realistic. She attained her associate's degree in 2016, and in March of 2017, she secured her first full-time adult job, and the family was excited and proud of her. A few months later, in that same year, on Thursday, July the 6th, which also happens to be our wedding anniversary, Kayla came home early from work because she was experiencing tremors and needed to get rest. My husband came home to check on her and then left out to pick me up so we could go to dinner. We arrived back at around 10 p.m. to find Kayla face down in her pillow. That was not her normal sleeping position. I called her name a couple of times. She was unresponsive, so I ran over to touch her. She was still warm, but I could not move her. I called my husband to come upstairs. We rolled her over, conducted CPR, and called the paramedics. Once they arrived, we were told, "Ma'am, I'm sorry, she's gone." I can remember hearing those words in disbelief. I felt like I was having an out-of-body experience. Not my daughter. But yes, she had passed, and we had no clue as to why. That was the worst day of our lives. There was nothing or no one who could have prepared us for this unexpected tragedy. During the months and days following Kayla's transition, my husband and I were determined to find answers about how or why, but it wasn't until we researched the Epilepsy Foundation website and saw the term SUDEP. Our Kayla had passed away from SUDEP. She had a seizure in her sleep and died. Why had none of her healthcare providers mentioned SUDEP? Now, as people of faith, we also believe that when it is your time, it is your time. So families of patients living with epilepsy live with the reality every day that their family member may have a seizure, fall down, and die. We live with that reality every day. We also live in a society where we are apprised of all sorts of risks, such as the risk of riding an amusement park ride, the risk of drinking and driving, the risk associated with smoking. Part of a parent's role is to keep their children safe. When we know about the dangers, we do our best to minimize our children's risks no matter what. Yet patients and families are not told about the risks associated with SUDEP by the very people we look to for information. You ask me, what do I want to have been told? There's 4 things. Number 1, that SUDEP is a true possibility for patients with epilepsy. Number 2, one of the risk factors associated with SUDEP is having tonic-clonic seizures or grand mal seizures. Number 3, people with night seizures may be at risk. And number 4, People who do not take their medications regularly may be at risk. You ask me when I would have wanted to be told, and I would say roughly around the second visit. During our annual appointments, the medical teams had at least 15 times to broach the subject from 2002 to 2017, place a pamphlet in our hands, or even direct us to the Epilepsy Foundation. But we were not given that opportunity. In 2019, my husband and I decided to turn our morning into mission and founded the Kayla Ross Perry Memorial Foundation, whose mission is to raise awareness about epilepsy and SUDEP, provide scholarships, and sponsor creative arts events for the community. I am here today to help in any way I can to motivate healthcare providers and families to be empowered to ask the question and to raise the conversation about SUDEP. My faith gives me strength to be forever Kayla Strong.
Yep, it was the epilepsy nurse who told me about SUDEP, yes. She asked me if I'd heard of it, and I, of course I said no, and then she went, it was going, okay. And so then she went into a bit more of an explanation about it, and of course you're going, what? Hang on, that's a thing? That's a thing? I mean, it does not surprise me, actually. It really doesn't surprise me, but is that, oh my gosh, okay. So, yeah, she sort of went into a bit more detail about it, and yeah, we took it from there. She did talk about, making sure you communicate properly with your family about when you're not feeling well and things like that, and that's definitely something. So the epilepsy nurse spoke to me about safety aspects and things that I could do to support that, and even just simple things like I was saying earlier, just open communication, having a lot better communication with my family about when I'm not feeling well, to avoid such risks. Yes, okay. No, I haven't had that conversation with my husband or any of my other family members because it's not a light topic, and it is my epilepsy diagnosis is still quite new for us, and it is something we're still trying to adapt to. So I don't want to just pull that out as well all at the same time. I don't want to make a massive formal issue of it. You're sitting them down and saying, hey, we need to talk, because it's not I don't want to treat it like a cancer diagnosis. I want to just say, oh, it's not lighthearted. That's not the right word. Just making sure that they're aware that it's actually something that can happen, is that, people can just, I will put it out there. So yes, when I went through the SUDEP checklist, there were a lot of suggestions of safety things guidelines that we could take on board. And there are things that we can put in place, definitely. And I'll plan on going through that with my loved ones, when the time comes that I do need to let them know about this condition. I do think that everybody who gets diagnosed with epilepsy should hear about this, but I think with a lot of health issues that are out there, it's not going to be the biggest thing that they need to be hearing about at the time, as much as just hearing that worst case scenario, this is something that is possible. But then obviously following that up with, realistically, it's I guess reassuring them with statistics about it, a few more, bit more information about it. But I do think they need to be hearing about it, definitely.
Hi everyone, I'm Sammy Ashby. I'm the Chief Executive at SUDEP Action, and I'm really pleased to be able to record this video for you today, and also to be joining you a little bit later on in today's session. The majority of bereaved people who find out about SUDEP Action weren't aware of SUDEP or that epilepsy could be fatal before their loved one died. And this is absolutely devastating to them, and I'm sure you'll hear that time and time again this evening. It leads to loads of what ifs, it leads to anger, and often there's really very complex lifelong grief as a result of that, all of which could be prevented if these conversations are happening. We know that epilepsy deaths, the majority of them are preventable. Some recent research that happened up in Scotland and looking at the Scottish population of people who with epilepsy who died suggested that up to 80% of those deaths could have been prevented. So there's a real opportunity here as a community that we can come together and try and lower that level. There should be no reason why preventable epilepsy deaths happen at all. And that's especially so because research has been really clear for a number of years that there are known risk factors linked to premature deaths in epilepsy. Sharing this information with patients, with their families, and with a focus on what can be done to improve those, to reduce those risks that might be available to that person, to reduce the kind of the harms that they may cause, it really can help. And it can not only help empower the patient and their families so they can go, right, I can go away, I can do this, I can get better at taking my meds, I can get better at my nighttime, at my sleep, at my routines. But it can also really help them to make informed choices about their care, about their treatment, and about their lifestyle. Most families that find us desperately wish they had been told this information so that they could have done all they can to improve their loved one's safety. And while they are very aware that that might not have changed their loved one's outcome, the death may still have happened. By being denied that information and being robbed of that opportunity to try and implement some changes where it might have been possible, they were stripped of that chance to try, and they live with that day in and day out. And it really is the main thing that people bereaved who find SUDEP Action want to see from us in our work. They want to know that what happened to them is not going to happen to other people. But it's not just bereaved people who say that. And actually, a lot of people with epilepsy that we work with and have worked with over the years, they tell us that they want to be told this information. They want to know this information early, and they want their health professionals to be straight with them, because then they can have a really honest, open and trustful relationship, because they know that their health professional is going to be honest with them, so they can be honest with their health professional. And they want to know this information early on in their epilepsy journey. A young person with epilepsy who's helped us with some of our work said, "It was never really talked about for me, so I did my own research to understand." Which means that when you mention it to a health professional, they don't take you very seriously. And I think that really sums up some of the issues that people with epilepsy face. If they're not getting the information from a trusted source, like a health professional, they'll go to Dr. Google, they'll go online, and Lord knows what they're going to find on there. So we have an important role here to educate people with the right information so they can make the right steps. And they also really want to be taken seriously. They want to be an equal partner in their care. We also know from our epilepsy deaths register that over 10% of people dying before diagnosis, and a number of people don't make it to their second health appointment. So there really isn't time to waste when you're starting these vital risk conversations. And as one of our bereaved supporters said to me, they'd much rather have been worried about that information, about hearing the word SUDEP for the first time, than to have to face life forever without their loved one. We asked health professionals about the barriers that they found when having these conversations when we were creating one of our checklists. The main thing that came up when we were talking to them was that they were worried about how patients might react. There were time pressures that meant it was really difficult, and just a worry about not knowing what to say in these conversations. And this is why we created our SUDEP and seizure safety checklist. We have one for adults and we have one for the paediatric population. This tool gives us structure to help any health professional follow that covers key risk information for patients during their existing appointments. It's backed up by the latest research evidence, and it provides prompt questions for anyone who's not very confident in starting these conversations off with their patients. It also helps focus the discussion on what risks that patient might be facing at that particular moment in time, and gives space to decide on what can be done about them. It's all about the action. What can we do, take away from this appointment to really reduce those risk levels before I see you next? And it also has lots of helpful signposting resources for both the health professional and the patient. We know from our Epsilon app that it takes at least 3 times of using the app for people's awareness of certain risks to go from no to yes. I wasn't aware to I am aware. So you have to keep coming back to these conversations time and time again, which is particularly important because we know risk also fluctuates over time. It goes up and it will go down for people. So you need to keep periodically checking in to make sure things aren't going wonky. But thank you for listening, and please do all you can to try and have these vital risk conversations with people with epilepsy, because knowledge really is power and it really can save lives.
Sammy, Edana, and Yasmin, thank you all so much for sharing your personal stories related to this really important topic. I'm going to spend the next 20 minutes or so taking a deeper dive into patient and care partner perspectives on SUDEP disclosure. I'll provide a brief historical overview, touch on some of the perceived barriers, talk about practical guidelines, and finally provide an overview on resources that will hopefully help you in clinical practice, again, as we talk about sudden unexpected death for patients and care partners, and really allow them to feel a sense of empowerment related to risk reduction. In 1904, Spratling wrote of epilepsy as a disease that destroys life suddenly without warning through a single brief attack. The term SUDEP was coined in 1997 and is defined as the sudden, unexpected death of someone with epilepsy who was otherwise healthy. In SUDEP cases, no other cause of death is found when an autopsy is done, and it's the leading cause of death in people with intractable epilepsy. And when you compare it to other neurological conditions, it's actually the second leading cause of mortality after stroke. The incidence of SUDEP is about 1 out of 150 patients annually, particularly in folks who have intractable epilepsy. And in 1 year, SUDEP typically affects 1 in 1,000 adults with epilepsy. And we originally felt that in 1 year, SUDEP affects about 1 in 4,500 children. But recent estimates have shown that the incidence of SUDEP is similar between adults and children. Again, about 1 in 1,000 deaths annually. Looking at risk factors, we know that generalized tonic-clonic seizures are not only associated with SUDEP, but we believe convulsions are actually the causal path to SUDEP. And this is really interesting. 3 seizures or more in a 12-month time interval leads to a 15-fold increased risk of sudden unexpected death. And while many of us on the call may think that having 3 seizures in a year is well-controlled epilepsy, what we see from the guidelines is that that increases the risk. So 3 seizures in a 12-month time interval increases the risk of SUDEP 15-fold. We also know that prone position, intractable seizures, non-adherence, and a lack of nighttime supervision are all correlated with sudden unexpected death. This provides an opportunity for risk reduction in terms of counseling patients and care partners about what we can do as a team to, again, modify risk factors. The American Academy of Neurology, the International Child Neurology Association, the American Epilepsy Society, our Scottish colleagues, as well as those in the UK, all advocate for SUDEP disclosure. So if our governing bodies are recommending educating patients about SUDEP risk reduction, why is it that we as healthcare providers are not talking? When you look at the literature, way back in 2006, there was a publication after the NICE guidelines that suggested that only 5% of neurologists discuss SUDEP with all patients with epilepsy. A similar study in 2010 by our Italian colleagues suggested that only 8.7% of epilepsy specialists discuss SUDEP with all of their patients. In a study in 2010, 50% of neurologists believe that sudden unexpected death should only be discussed in patients with difficult to control seizures. They also suggested that this information should be discussed with certain families, particularly those with medically refractory epilepsy, nighttime seizures, symptomatic epilepsy, or surgical candidates. This is a challenge because it really suggests that there's a paternalistic approach to determining which patients deserve to learn about SUDEP. Interestingly, in this same cohort, 91% of parents felt that it was the physician's responsibility to talk about SUDEP, and in fact, they wanted to be aware of risk reduction. So what we see here is a disconnect between what patients feel they deserve to know and what physicians and healthcare providers feel is necessary in terms of SUDEP disclosure. A study in the U.S. of 43 healthcare professionals also looked at the perspectives of disclosing SUDEP, again, between physicians and nurse practitioners. And interestingly, some of the reasons for not disclosing SUDEP was the perception that it was morally wrong to give patients information about a complication that's poorly understood and difficult to prevent. And also, physicians felt that if there were no other options for patients, that disclosing SUDEP was not helpful. Interestingly, and I'm happy to see that the advanced practice providers or nurse practitioners in this study actually felt that it was a moral responsibility to discuss SUDEP with patients, and they felt that patients and their care partners had a right to know, and they wanted to ensure that patients were receiving accurate information. So really interesting when we think about the disconnect between physicians and patients and the interest in nurse practitioners in terms of disclosing SUDEP for patients and care partners. Another study in 2014, this study suggested that only 7%, about 6.8% of neurologists discuss SUDEP nearly all of the time, and it was more likely to be discussed if that physician had a patient who died of SUDEP 2 years prior to survey completion. It was less likely to be discussed. And again, we're seeing a pattern here of misperceptions. So in this study, it was less likely to be discussed if the physician felt the patient was at low risk and had a perception that learning about SUDEP would lead to negative reactions and also challenges with mood. And again, they felt that a lack of preventative measures was a reason for not being able to discuss SUDEP. Now, we've just learned from the American Academy of Neurology that there are some risk factors that we can modify, again, that can potentially lead to risk reduction. Another study in Australia, and Germany, and Swiss indicated in 2016 similar findings. In 2021, a North American study suggested that only 12% of neurologists discuss SUDEP with all of their patients. This is interesting. This is a global survey of over 27 countries and over 1,000 neurologists. In this cohort, and they looked at systematic reviews and also implemented a survey really asking these neurologists and epileptologists if they felt that all patients with epilepsy should learn about SUDEP. And what they found was that only 12% of the epileptologists and neurologists discuss SUDEP with most of their patients, and they defined that as discussing SUDEP with 50 to 90% of patients. And the respondents felt that some patients with epilepsy should be told about SUDEP. Again, not all patients, but only certain patients. And typically in this survey, the perception was that only patients with poor compliance and medically intractable epilepsy, as well as those with tonic-clonic seizures, should be informed about SUDEP. They also cited the risk for not discussing, or the reason for not discussing SUDEP was the perception of inducing unnecessary fear. And we'll talk about this a little in a moment here. Diving into the global differences, what we saw, again, the question was, should all patients with epilepsy be informed about sudden unexpected death? In Africa, about 18% of neurologists felt that all patients should be informed about SUDEP. In the Middle East and Asia and Europe, 26 to 30% of neurologists. In North America and South America, there were 62 and 50% respectively who felt that all patients with epilepsy should be informed about SUDEP. When you look at some of the differences, the perspective was that there were challenges or differences in terms of resources, education, legal frameworks, and ethics that kind of led to the global disparities or differences in SUDEP disclosure. When you look at the literature from patients and care partners, and what we nicely heard from our family members who discussed their personal experiences with SUDEP earlier, is that the overwhelming majority of patients and their care partners want to be informed about SUDEP, and they don't have a long-lasting anxiety after it's discussed. When you look at the literature, it suggests that the anxiety associated with SUDEP disclosure subsides in about 3 months. We also know from the literature that between 80 and 100% of patients and care partners not only want to know about SUDEP, but they feel it's their right to be informed. And you see the references here. This information was actually supported by a study that we did at Ohio State, where we looked at patient and care partners' perspectives on SUDEP disclosure. There were approximately 100 patients and care partners, and although 30% of those in our cohort admitted that SUDEP disclosure made them more frightened, 100% said that it was their right to be informed. This was regardless of age, the duration of epilepsy, and also psychosocial factors. So 100% of patients and care partners in our study felt that it was their right to know about SUDEP and that it was my job as a healthcare provider to disclose such information. We also wanted to know when patients should be informed about SUDEP, and in our study, about 90% suggested that they wanted to know about SUDEP soon after diagnosis or at the initial appointment. So either at the beginning of the appointment in terms of diagnosis or shortly after the patient had been diagnosed. This is pretty consistent with other studies. This is a summary of a publication from 2023 when we wanted to know the mode of counseling for patients and care partners. And what we found is that SUDEP discussion at the time of diagnosis or soon after was perceived as really important by patients and their care partners. They preferred that the discussion be initiated by the treating neurologist face-to-face and also providing written information. And it was really important to allow for additional follow-up in terms of SUDEP disclosure. Caregivers wanted to decide if and when a child should be informed about the risks of SUDEP. And this is really interesting. I'm really looking forward to our discussion after this presentation, particularly for those of you who work in the pediatric space. Again, your perception on when and if a child should be informed about risk reduction. Again, what's really important is the idea of diversifying the information and how it's received. So face-to-face written information and repeated discussions are really some helpful clinical implications for your patients and their care partners. Wanting to move now to some practical guidelines on how you as a healthcare professional can discuss patients. And I am a strong advocate for discussing SUDEP with every patient. So this is a case where a patient is stable, compliant, and seizure-free. My typical approach is to say, really to talk about SUDEP when you're talking about the importance of adherence. And I'm sure everyone on the call talks about the importance of ensuring that your patient is taking their medicine as prescribed. So again, you can discuss SUDEP when you're talking about continued adherence. I will typically say, keep up the good work. Missing a dose of your seizure medicine can lead to breakthrough seizures, life-threatening seizures, and can increase the risk of something called SUDEP. And then I'll go on to say SUDEP stands for sudden unexpected death in patients with epilepsy, and I'll talk about the risk factors. In cases where your patient is stable or non-compliant or stable or compliant and perhaps not seizure-free, this is typically my approach. Have you heard of SUDEP? I'll often talk about Cameron Boyce. Many of you may be familiar with Cameron Boyce. He was an amazing Disney actor here in the United States. He, by the way, had, I believe, 6 lifetime seizures. So this was not a patient with epilepsy with one of our difficult to control epilepsy syndromes, LGS Dravet. Cameron Boyce had, I believe, 6 or 7 lifetime seizures and died of sudden unexpected death. So I'll reference Cameron Boyce, and I'll say that SUDEP stands for sudden unexpected death. In patients with epilepsy, it happens in about 1 in 1,000 adults. I'll talk about the risk factors, and we've mentioned this. Patients with uncontrolled seizures, those with nocturnal seizures, particularly convulsive seizures who are not monitored at night. Not taking your medication can increase the risk as well. You can continue to reduce your risk by, and we'll talk about risk factor modification. I'll also very commonly tell patients that my goal in providing this information is not to scare you, but to educate you. And patients and care partners can't reduce the risk of something that they don't know about. And that's our job as healthcare providers, to provide them with information so that they can make an informed decision to empower them in terms of risk factor modification. For those patients who have comorbid anxiety, I typically say I'd like to give you some information on how to reduce your risk of breakthrough seizures, reduce your risk of life-threatening seizures, and reduce your risk of something called SUDEP. SUDEP stands for, and we'll continue that conversation. Again, my goal in telling you is not to make you anxious, but to educate you. Really important that you allow patients and their care partners to understand that they can't prevent something that they don't know. And again, our job as healthcare providers is to provide that information. I also will often talk about collaborating and working together with that patient and care partner to reduce risk. So aiming at 0 seizures, nocturnal supervision, providing information on an acute seizure action plan, are all things really not just for your patient with comorbid anxiety, but are things that you can talk to all of your patients about in terms of risk modification. For patients with uncontrolled nocturnal seizures, we have a similar discussion. Again, my job is to provide you with information to reduce your risk. We'll also talk about a list of different options, and this is important that you are providing your patients and their care partners with information about seizure reduction. So providing information about epilepsy surgery, neuromodulation. When I first started in the epilepsy space, there were only 6 anti-seizure medicines. In some countries like the US, we have over 30. Certainly, those of you in some of the other countries may not have those numbers, amount of anti-seizure medications, but you have different resources. So just making sure that you're providing those patients with a list of different options for seizure reduction, talking to them about nocturnal devices if you have them available in your country, a baby monitor, smartwatches, the Embrace, the Infant. Again, whatever you have to encourage those patients and care partners to ensure that the nocturnal seizures are identified is really, really important. Quickly wanted to go over some practical resources. The UK Sutton Action is a charity that focuses on reduced morbidity and mortality. Really, really helpful resource. In the U.S., we have the Epilepsy Alliance, the Epilepsy Foundation of America, epilepsy.com. By the way, for those of you in different countries, you can access epilepsy.com. If you have access to an internet, you have access to those resources. Child Neurology Foundation, we've referenced the American Academy of Neurology guidelines. SUDEP Aware, wonderful organization in terms of resources. This is a copy of the handout that I use for my research study. It is written at a 5th grade reading level, and this was actually a handout that was created, I believe, in collaboration with SUDEP Aware and the Epilepsy Foundation of America. You can find this online. The SUDEP Aware app, this is something that my colleague Nancy, who's on the call, provided. This is a resource that actually looks at risk factors. There's another one that's a little shorter, the SUDEP 7. This again is a revised overview looking at risk factors. It provides an opportunity for you to calculate what your patient's risk factor may be. Again, I believe that it's important to disclose SUDEP to every patient, regardless of what the perception is of their risk factor. Again, we talked early on about 3 seizures increasing the risk of SUDEP 15-fold. So finally, when you think about the importance of SUDEP disclosure, as healthcare providers, we have an opportunity and really can have a dramatic impact on patients and families in terms of risk reduction. Patients and their care partners want to be informed about SUDEP. When to discuss this should depend on patient readiness. Our patients, however, have taught us that they want to learn about SUDEP early on, and that this information should be reiterated as often as possible. Try to keep it simple. Talk about SUDEP when you're talking about the importance of adherence, and also remind patients that your role is to empower them so that they can implement risk factor reduction. Not only do patients want to be informed, but it's their right to know. I'll conclude this discussion by asking those of you who are healthcare professionals, if you or your loved one had an opportunity to learn ways to reduce the risk of sudden death, would you want to know? And if the answer to that is yes, then we owe that to our patients and their care partners. Thank you.
Thank you for those wonderful talks. And we now invite our panel to come back and to open the Q&A. I think certainly if you work in epilepsy long enough, all providers will unfortunately have the experience of losing a patient to SUDEP. So this is a really, really important topic in our day-to-day practice. There are a few really interesting questions here in the chat, and we'll go to 2 of the questions which I think are related. And these may be addressed to you, Lucretia, but we invite anybody to jump in. The first question was, when you have the SUDEP conversation, do you do this with the parent or caregiver first, rather than discussing it in front of the child? And related to that is, as a nurse, I discuss SUDEP a lot, but the question is, the patients very often don't share the topic with family members. So how should we best approach the issue, first of all, of talking with a parent of a child? And how do we talk about SUDEP with a family member, with a patient who is then reluctant to share the news with someone else?
Hi, thank you for the question. So I am an adult epilepsy specialist. So my experience with children is something that I don't have a lot of. So my general population is age 18 years or older. And in that patient population, I will discuss SUDEP in front of the patient. As you guys know, an 18-year-old has an opportunity to implement adherence interventions. And so their ability to appreciate their role in reducing the risk of SUDEP is really, really important. And in terms of family member disclosure, if a patient presents to the clinic by themselves, I typically will educate them on the importance of educating their family members, because if they're in a convulsive seizures, they cannot initiate seizure first aid. And so I am very intentional about the approach for patients to share information and disclose that with their loved ones because of the reasons previously discussed. I think it gets a little more complicated if you are in a situation and a patient specifically tells you that they don't want you to disclose that information. You have to support that patient's wish. But in general, I am very intentional and direct in terms of my educational interventions, encouraging those patients to educate their family members, because family members can help with risk reduction. Again, being able to assess nocturnal seizures is something that family members are directly involved in. And also the seizure first aid intervention is directly correlated with family members. So I am very forceful, if you will, in terms of encouraging collaboration for patients and their family members.
Thanks, Lucretia. you spoke at quite some length about wearables and devices that people can use at home. One of the questions in the chat is, does using an epilepsy pillow or an anti-suffocation pillow reduce the risk? And is this something we should be recommending to families? And I think, perhaps Sammy may like to address this question.
Yeah, of course. We would always say at the charity that devices like pillows, wearables, they can be part of a risk reduction plan. So they may play a valid part, but there's no device out there, no kind of quick fix that is proven to reduce the risk of SUDEP happening or proven to stop SUDEP from happening. So it really needs to be one piece of a larger risk reduction jigsaw. And the real focus that we want people to be considering and to be doing all they can to kind of tackle is how can they get their seizures under as best control as possible. So hopefully all of these devices aren't as necessary. But we do realise that they give people peace of mind as well. So it's a real balancing act between kind of reducing risk as much as possible, while also giving people peace of mind and enabling them to live their life and have a good quality of life as well.
Yeah, I think, one of the challenges too is the notion that if somebody has a big seizure at night and they have a sleeping partner, hopefully the partner would wake and turn the person over, and that simple activity of just changing the person's position can in itself be life-saving. This really has two-part question to it. First of all, for adolescents or young people who are trying to learn to live an independent life, it's a big worry for parents, and I have many times in my own practice heard of parents sleeping with adolescent young men, sleeping in the same room or even in the same bed, well into their early 20s. One of the questions is, how do we think about that? What sort of advice would we give to families who are trying to allow a level of independence in a young person who may be substantially at risk? First part. Second part is, what do you do with a young university student or somebody who wants to live alone and for whom there's fear of being alone and having seizures that are unwitnessed? Anybody can answer this question.
I think
unfortunately, Yasmin's not on. So yes, carry on, Sammy.
No, sorry. I would say when it comes to kind of gaining independence, it really is going to be that balancing act again, isn't it? Of if we start with these SUDEP risk conversations early, we've started them young with that person. Hopefully they've had exposure to kind of what the risks might be for them, why it's important to do what they can over time, so that by the time they are really starting to gain that independence, where their parents are really starting to rein back on what they're able to do to kind of keep an eye on their epilepsy, they've got a good grounding themselves, as Lucretia was saying, kind of what's important, how you can take steps to reduce your risk. And hopefully they'll make informed choices about living safely with their epilepsy when they're more independent. And hopefully, again, as we were saying earlier, they'll feel comfortable enough because they'll be confident in their own risk reduction abilities. They can talk to their flatmates, university mates, to try and get some help, whether it's basic seizure first aid or whether it's a reminder to take their medication before they go out for their lectures for the day. Education and starting out really young, so people just feel confident that it's part of their daily condition management rather than this scary add-on is a really important step.
Any other comments on this issue of, trying to maintain independence and allow people to live with as much confidence as possible?
I echo, Sammy, that was beautifully stated. I love the idea of empowering the individual and also ensuring that there is a component of a collaboration with family members and also, as she mentioned, other students at the university level. So really important, again, to emphasize how we can empower individuals to minimize their risks and also collaborate with family members and peer partners.
Excellent. Thank you, Lucretia. Obviously SUDEP can impact any form of epilepsy, even though the literature focuses, certainly the earlier literature focuses very much on seizures that are uncontrolled, pre-surgical patients. But just to highlight that pretty much, the risk can occur across syndromes, including JME, which I think was what Kayla died with, Edana. So, and I know that you were not told about even the possibility of SUDEP, and I think this is very common in specifically JME. But one of the questions in the chat is that this person has epilepsy. She was diagnosed at 15 years of age, and nobody told her about SUDEP. She found out about it accidentally, and there's two questions, or a comment really, that she wished she'd been told earlier. But the question is, how do clinicians regain the trust of patients when they find out that there is this risk that they've been living with for 15 or 20 years? Do you have any suggestions for regaining trust where someone may be angry that they weren't told?
That is a really, really, really good point. And I think, I do a lot of education of our residents and our physicians and other nurse practitioners on a national level. And this is one of the key reasons that I think it's so important for us as healthcare providers to disclose information. Patients come to us for expert opinion. And so I actually just had this conversation. I did this presentation with our residents, and I provided a similar example. The worst thing for me is for a patient to see this information on internet and to come to me and say, why didn't you, as my expert, as the person that I confide in, why didn't you give me this information? And so 100%, I think that it creates a challenge with trust. I don't think, I've never had that conversation where someone learned about SUDEP outside of our conversation. I have that as a part of what I call a smart set. Every single patient that I see, I talk to them about SUDEP, every single patient. So fortunately, I've not had that experience, but I do think in terms of regaining trust, that provider needs to be comfortable and transparent in terms of discussing why they didn't discuss that with the patient. And, I think, oftentimes it's important to allow yourself the opportunity to apologize. In my mind, I think it's a paternalistic approach for doctors and other providers to determine which patients deserve to learn about SUDEP. All patients deserve it. And so I think that if that were me, I would apologize for not providing that information and encourage that patient to ask as many questions as they have for me, and also tell them that I would love to try to move forward so that we can work in collaboration. I always share with my students that our job as healthcare professionals is not one of dictatorship, but rather of collaboration. And you guys are really stakeholders, patients and care partners. So again, our job is to give you information so we can work together as a unit to move forward to reach that goal of 0 seizures and minimize related risk. So I think just being transparent and even apologizing for not disclosing it. A lot of healthcare providers, as you just learned, are very hesitant to talk about SUDEP because they're concerned that they're going to induce unnecessary fear. I don't agree with that. We have literature that supports that you guys want to know. But, I think we have to be a little gentle with some of those healthcare providers, because I always say it's not what you say, but how you say it. And we have to do a better job teaching some of these healthcare providers that are hesitant to disclose the information about proper ways. I love that Sammy talked about some innovative ways to make the conversation simple. I think we sometimes make this conversation too difficult. I am very convinced that we can talk to patients about anything, and that it's not what you say, but how you say it.
I would just wanted to add something as a parent of a child who lost a child, and it was not shared immediately. About a week or so after Kayla transitioned, I called her adult neurologist, And through my tears, I was communicating that we wanted to know. We would have wanted to know about the risk of SUDEP. We wanted to know. And he listened attentively, and he shared some of the information that Lucretia was sharing about the hesitancy and the that physicians primarily are falling on two different spectrums. Some feel comfortable about sharing and some do not. And which is why we're doing what we're doing. We feel that it is very important to share that information before the patient transitions. So, that's what I have to add. If any providers are on now listening, yes, as a care provider of someone who had epilepsy, even if you're uncomfortable, you can put a pamphlet in my hand and let me go out the door. Let me be able to at least read it, and then I could come back with questions. So.
Thanks, Edana. It's very important, obviously, to hear your perspective, and I'm sorry we can't hear the perspective of Yasmin. But the purpose today wasn't really to go into what we do and don't know about the mechanisms of SUDEP. But I'm sure that it must have been very confusing to you to have had this experience and then to be told that we don't really understand the mechanism of the SUDEP very well. Mm-hmm. And I think this is a barrier as well, and it's a documented barrier. There are very few detection systems that can prevent it. But it certainly, the fact that it may alarm, something may alarm, and call a caregiver in is a helpful thing. I just want to see if there's another. We've got 1 or 2 minutes just to see if there's any more in the. There is one question here about the risk assessment. Does anybody systematically use the SUDEP risk assessment with patients? And Edana, I don't know if you may not be familiar with that, but Sammy and Lucretia can perhaps jump in.
I know from the UK perspective, and also from our collaboration with Epilepsy Action Australia, we created the SUDEP and seizure safety checklist, which Lucretia showed earlier in his slide deck, as a real simple way to not have SUDEP right at the centre of these conversations, but to have risk at the centre of these conversations. What are the different risk factors that we know can predispose someone to being more vulnerable to SUDEP happening? What are they? Does that person have it present, and can they do anything about it? What steps could they take, either as an individual or in conjunction with their healthcare provider? And we've distributed that across the UK, and we've got over 1,800 health professionals from across all settings. So neurologists, right down to paramedics, learning disability specialists, nurses, the whole lot. We have people using this tool to help educate and help break down those conversation barriers about what can be done to try and reduce risk. And we've got a few hundred people using that in Australia as well.
I love the idea that you all created that. I don't use that in my practice, but certainly it provides an opportunity to initiate that dialogue. And I think that's the core of the take-home message today. What can we do to move forward with initiating the dialogue? I think I mentioned this, one of the reminders that I have for myself is on my progress note. It is embedded in my progress note. So there's not a patient that I see that there's not a reminder for me to talk about SUDEP. It's a challenge. Many healthcare providers have 20 minutes to talk to patients and care partners. So one of the barriers, as Sandy, I think, mentioned earlier, is the time that they feel it takes to talk about SUDEP. Again, I think when you're talking about the importance of adherence, you add that conversation. And so we hopefully are all talking about patients about the importance of medication adherence. And so why not add your SUDEP conversation into that, provide patients with written information. so that you can review that information and then bring that back with questions, as I think someone mentioned earlier, and just allowing that conversation to continue. Even if you're just giving basic information during each visit, the opportunity to be repetitive with that information is really, really important. And we've learned that from patients and care partners.
Lucretia and Sammy, and certainly what we've learned from Edana, and we thank you for sharing such a sensitive story, is that risk conversations are not a one-time thing, and this needs to be approached many times during the course of and all epilepsy actually. But it is a difficult topic, and I like Lucretia's matter-of-fact approach to it, because I think that that's more helpful to people than trying to mask the problem. And I think encouraging people to live a healthy life as well as they can, with as much information as they have, is really the only way to approach this. We are at the top of the hour, and I think we'll have to stop at this point. But there were a lot of very interesting questions in the chat, which I'm sorry we have not got to. We will try to answer those remaining questions if we can in an email, or you can email us, and we'll try to get those answers to you. So this just brings me to the end to say, if anybody would like to join the nursing section of the ILAE, we welcome new members. Our membership has grown enormously over the last 3 years. It's a wonderful organization to be part of. There's no charge to be part of it. And just to thank ILAE staff for supporting the offering today. And thank you again to our wonderful speakers. Have a good night wherever you are in the world. Thank you.